I guess we're gonna get started. I know that because of the change of venue, some people will be strolling in, and I actually bumped into a couple of people going wrong direction as I was coming here. It's a great pleasure to introduce Dr. Joe Ditre, today's Grand Round speaker. He's a currently professor of psychology at Syracuse University, and he's also a clinical psychologist who holds secondary appointment in Department of Medicine at Upstate Medical University in Syracuse, as well as Center for Integrated Healthcare at the Syracuse VA Medical Center, where we also do a lot of collaboration with. He's also director of Pain and Addiction Research Lab and the program for advanced health equity in pain and addiction as well. Now, Dr. Ditre received his bachelor's degree at SUNY Binghamton and received his master's degree and Ph.D. at University of South Florida. Then he joined a Department of Psychology as a faculty at Texas A&M at first in 2010, and later moved to Syracuse University and has been there for the past 10 years. Now he's at the rank of professor. He has been a prolific scholar who has published over 100 scholarly works, and his program and research has been continuously funded throughout his career by NIH. And he's focused on something that our department is really interested, this bi-directional relationship between pain and addiction. And his research has successfully applied multi-method approach to address complex interaction between pain and misuse of addictive substances and prescription opioids, nicotine, alcohol, cannabis, benzodiazepine, etc., while incorporating other biopsychosocial factors, including psychopathology and social determinants of health, really a biopsychosocial researcher. For his work, he has received many awards. Among them, he's a recipient of Distinguished Scientific Early Career Contribution Award by the American Psychological Association Division 50, and also Mitchell Max Award for Research Excellence by NIH Pain Consortium. And he has been on numerous NIH study sections and several editorial boards for his outstanding work. And even more impressive, by the way, is his mentorship of many undergraduate students and graduate students and junior faculty in clinical psychology programs at Syracuse and beyond. Particularly his mentorship of several junior faculty and investigators at Meharry College, a historical Black college in Nashville, Tennessee. I can go on, but obviously we'd like to welcome Joe for his what is to be a very interesting talk about pain and addiction. So Joe.
Thank you. Thank you, Dr. Lee, for that introduction. Thank you all for coming today and for having me here. I am excited to talk to you about this topic. It's one that we hear about separately a lot, but maybe not in concert as much. So let me move through a few slides here. All right, and just an outline to start with so you know where I'm going with this. I'm going to start with a brief program overview, although Dr. Lee did a great job of that for me already. And then I'm going to talk about interest in pain and substance use. So this is both in national media and empirical interest, and then provide an overview of each one in turn before bringing that back together in a reciprocal model. And then I'm going to talk to you about a few example studies that represent the kind of work that we've been doing, and then close out by talking a little bit about where we're going, although future directions will be intermixed throughout. So just like Dr. Lee mentioned, this is a multi-method approach. Well, that means we use a variety of methods in these studies. We do epidemiological analyses, use large national data sets, do experimental studies that are truly translational in that they're informed by previous animal studies. You can think about that as bench to bedside and back. And then, of course, translating these experimental findings into the development of novel interventions. acute and chronic pain is a major part of what we're looking at, and it depends on the study which one we're focusing on. The use and misuse of addictive substances, including all the ones that were mentioned before, and frankly more. Some of them are very different in terms of how they interrelate with pain, but there's some commonalities as well. Comorbid psychopathology is also central here, as people with chronic pain typically present with other comorbid disorders, and a focus on social determinants of health in this process. These are the driving factors in health disparities in racial and ethnic and socioeconomically disadvantaged populations. And ultimately, this goal is to advance health equity in pain and addiction. So in terms of this interest, right, there is interest in relations between pain and substance use, but you might not see it if you're not looking for it. And here's just a few snapshots that I took randomly, different places across the internet that were talking about these types of relations. I don't know how well you can see that, but some refer to relations between alcohol and pain, vaping and low back pain, painkillers and alcohol, the role of medical cannabis, and the role of smoking, cigarette smoking in the context of chronic pain. And I wonder if after this, you might even catch more of this. Now, in terms of empirical interest, this is a chart that was included in a review paper that we did on the topic fairly recently. And what it represents is the number of published studies that are specifically focused on relations between pain and each of these substances. Now, that'll clear out a whole bunch of other filler material that you might think in there, like chest pain or something like that. These are specifically focused on interrelations between the experience of pain and a substance. And as you can see over time, these are in about 8-9 year increments. It's increased quite a bit for all of them. And you can see cannabis really taking off now, which makes sense given increased legalization. Now, just in case you don't focus a lot on substance use, I wanted to start with a broad overview of what substances do people use. And on the left, you see that about 40% of people report no past substance use at all. That means 60% of everybody else does report past month substance use. So if you're wondering how many people out there are using alcohol and other drugs, it's about 60% of people if you use a past month marker. And then on the right, you can see how that breaks down with alcohol being the most common, followed by tobacco and cannabis, and a few others interspersed. And that's in millions that the representation is. It's also important to highlight in the context of substance use disparities. Substance use disorder does disproportionately burden Black, Latinx, and Indigenous people, as well as those from economically disadvantaged status. There's higher rates of morbidity, mortality, and adverse social and legal consequences that's associated with these disparities. And it's important then to look at what are the driving factors here, including social determinants of health. And these include a few that I've listed here, but there are more. And some we're focusing on more than others right now, but all require addressing. That includes systemic and structural racism. And then importantly, the connection between racism and stress. Now that can be chronic stress over time that leads to neurobiological vulnerabilities that lend themselves to substance use disorder, but also the accumulation of daily slights and microaggressions that have been linked with a greater likelihood of substance use. There's also treatment-related biases like conscious and unconscious biases, and the role of stigmatization and criminalization, particularly criminalization being specific to substance use relative to pain. And substance use treatment tends to be less available, less successful among individuals from racial and ethnic and sexual and gender minority groups. So there's a lot to unpack just on the side of substance use. If we switch our attention to chronic pain, this is a pretty updated representation of the prevalence of chronic pain. There's different ways of defining that. Typically, it's pain that endures beyond 3 months or when it should have gone away. Other cutoffs use 6 months. So depending on what your criteria are, you will see different percents. This one represents 50 million. There are ways to represent 100 million. But the point is that this is a common and highly impactful condition. And then high impact chronic pain is another category that reflects greater disability and functional impairment among people with chronic pain. And even those numbers are very high. As you know, we're in the midst of a prescription and otherwise opioid epidemic, and 22% of people with chronic pain currently use prescription opioids. I'm highlighting that because some of the work that I talk about later is going to focus on prescription opioid medications. Once again, it's important to highlight the disparities, this time in terms of pain impact and treatment. So for example, patients belonging to minoritized groups report more severe pain-related functional impairment. That one's important. The physical impairment, the day-to-day ability to operate is impacted in a disproportionate manner. There's greater comorbid depression and anxiety. There's less adequate treatment for acute and chronic pain, and they're less likely to receive opioid analgesics, regardless of how much pain intensity they're reporting. Again, driving factors, social determinants, structural barriers, conscious and unconscious biases. Now, these are interesting because in pain, the experience is inherently subjective, which means you have to listen to the person who's reporting the pain to you. So the role of bias, or unconscious or conscious, is potentially profound in that. And then you have subtle and overt stigmatization, which can actually lead to pain underreporting. And that's a problem because if people are not reporting their pain accurately, they won't get the treatments that they need. And then lastly, of course, language barriers. Again, completely subjective expressions of what one is experiencing requires the ability to communicate well with a provider. Okay, so we've covered each of those individually, substance use and pain, and now we want to bring them together and talk about this co-occurrence. The co-occurrence of chronic pain and substance use disorder, well, it's variable depending on which substance you're talking about, what the source of pain is, what the duration of pain is. But nonetheless, there's great overlap regardless of which combination you're looking at. Also overlap with other psychiatric disorders, but you heard that already. But what that means is that in the comorbid or co-occurring presentation of chronic pain and substance use, you're seeing even more of that, right? You keep on upping the ante. And that goes across the board in terms of more severe pain and impairment. So this is saying people with chronic pain plus a substance use disorder are reporting more pain and impairment than people with either one alone. And you see greater use and misuse of opioid medications. And of great concern and focus of my work is that the study and treatment of these have been typically siloed. That means we need greater integrative conceptualization, the integration of treatment, the development of culturally sensitive approaches that can be delivered in existing systems in a way that they're not currently. That requires collaborations between healthcare systems, community leaders to identify and address these social determinants. So now that we've laid all that out, let's talk about how this interplays. So I've been working on this reciprocal relationship for about 15 years or so, and it's evolved over time, but the basics of it are just like any reciprocal relationship, and that one is influencing the other and vice versa. So that's what it looks like laid out all at once, the effects of substance use on pain, and in turn, the effects of pain on substance use. And I'm going to unpack these in turn. Let's start with the effects of substance use on pain. In fact, that's the one we've heard about the most in the literature over the longest period of time. And there's reasons for that because there's really interesting data out there. The first set focuses on acute analgesia. So it's the idea that this range of substances is producing acute pain inhibitory effects or acute analgesic effects. And almost all of them do to some degree, but how much of it you need to take to achieve pain inhibition, that is an area for debate. But nicotine, cannabis, alcohol, all of these are associated with some degree of short-term pain relief, especially if you're expecting it. Now, if you flip that around, this is an interesting term, abstinence-induced hyperalgesia. What this is getting at is someone who's taken substances for a fairly long period of time or in heavy amounts, and you say, and they have, let's say, a painful condition, as many of them do, and you say, okay, it's time to quit, and I'm quitting. What you might expect, if you knew to look for it, is an increase in pain sensitivity. that comes as a function of taking away potentially this analgesic effect, right? This coping strategy. So in the context of substance use treatment, to anticipate an increase in pain, which might itself promote relapse, we'll get into more of that later, is a critical consideration. Finally, the biggest literature in this area and the most conclusive is the causal role of substance use in the onset and development of chronic pain. That means for some substances and for some types of pain, not all of them, if you control or account for all the other factors that one can in predicting these, you still get unique causal variants accounted for by substance use. For example, cigarette smoking in the context of low back pain. Anyone who works in the area of spinal fusion knows that quitting cigarettes or weaning off of nicotine is an essential component prior to that type of treatment. And this is why. All right, everyone with me so far? We're good? All right, I'm going to keep moving. All right, we're switching directions now to the effects of pain on substance use. Now, this is one that wasn't covered that much in the literature. And as somebody who did their graduate training in an addiction lab, and I was discussing all of this with my advisor, I was talking about some of these interesting effects that we saw, that substance use could lead to pain. And we had a discussion about, well, what about from an addiction standpoint? And we know that negative affect, anxiety, depression, things that are comorbid with substance use can also motivate and prompt substance use, serve as proximal antecedents of substance use. So that from there came the idea, maybe we should be focusing on the experience of pain as one of those proximal antecedents, because it potentially has such relevance to such a large population of people with persistently painful conditions. So that's, does pain motivate substance use? Can pain be an individual causal driver of drug-seeking behavior? The use of substances to cope with pain. This is readily endorsed by many people with pain who use substances. They have no problem telling you, if you ask, yes, I use alcohol to help cope with my pain. And I bet to everybody in here, right, this makes perfect sense. Like, you could totally see it. It's just a matter of asking about it and then thinking about it in a clinical way. Pain is a barrier to reduction in abstinence. So there is evidence that people with painful conditions have a harder time quitting substances than people that don't. But you wouldn't know that if you were in substance use treatment and never asked about pain, right? And then if you had considered the role of pain, maybe there's something else that could have been added to the treatment or addressed to help them be successful. But instead, we just see prevalence rates not change as much for some groups versus others, like individuals with pain. And lastly, if pain does prompt this, if pain does motivate substance use and you're getting into this vicious cycle, then you have an increased risk for developing a substance-related disorder where maybe previously there was not one, right? You might have escalation of use over time. That's a mouthful. There's a lot going on here in these slides. So just putting it all together, it's the idea that pain and substance use can influence each other in a reciprocal manner to ultimately help maintain and progress both pain and addiction-related outcomes. And that's the thesis. That's the basis for the work that we're doing and that others are doing and adding to this. So this has been evolving over time with new information added. And that's some of what I'm going to share with you today. So no, this didn't just end. We're just beginning now. We're going into the next part. I'm a clinical psychologist by training, and I think it's really important to focus on some of the theoretical mechanisms and guiding frameworks that inform this work and will continue to. One of those is the allostatic load model of pain and addiction. Put simply, this is the idea that chronic substance use can dysregulate overlapping neural substrates and homeostatic pain mechanisms to engender a persistent imbalance that favors pain facilitation. That's a lot of words up there, but what it means is that by using drugs over and over for a long period of time, you're messing up parts of the brain that govern other parts, like pain perception and pain experience. And what this means is you could actually be setting yourself up to experience greater pain and greater impairment in the context of pain, strictly as a function of dysregulating these overlapping regions. Another guiding theoretical framework is the idea that pain may come to be conditioned as a cue for substance use in the most classical sense, but also in terms of incentive sensitization. So pain over time, via these repeated pairings between the experience of pain and substance use, can come to trigger excessive motivation that leads to drug seeking and relapse, even if that's not part of the conscious approach to why you're doing it. This is highly consistent with negative reinforcement models of addiction motivation and self-medication models, which I'm sure many people have heard of. So in that sense, the use of substances to self-medicate pain and the effects of pain and the impact of pain, I think makes a lot of sense from a theoretical standpoint. All right, so let's get into some more interesting applied stuff. These are examples. These are actual studies that we've done. I've picked a few to try and highlight some of these relationships. And the first one is focused on pain and nicotine in tobacco. So first, let's talk about those prevalence rates. Now, no prevalence rate is perfect. And I'm not saying these are the absolute for sure numbers because they're shifting all the time. And it depends on where you assess these things. But what you have in the green bar is the prevalence of cigarette smoking currently, right now in the general population, right around 12.5%. But if you look to people who report that they have chronic pain, like in national surveys, you see prevalence rates that are much higher, maybe in the range of 30 to 40%. And then if you look at clinical pain, now these are people who are seeking treatment for their pain. So this data is coming from pain clinics. And they say, well, what's the percentage of people smoking? And we see numbers ranging from 49 to 68%. Another interesting fact here is that Mayo Clinic tracks this stuff, and they have a nicotine dependence treatment program as well. But they tracked what are the rates of smoking among people who continue to have pain. And what they found is that rates of smoking have stayed steady over the past 10 years or so, while we all know perhaps that rates of smoking in the general population have gone down pretty significantly. Not enough, and not among everyone, right? Because that 12.5% doesn't tell the whole story of how many people are captured in that percent from different demographic and disproportionately represented individuals. So you got bigger, much bigger numbers in certain groups, and one of those is pain. So we've done a lot of research on this topic. Smokers versus non-smokers, if you're comparing that, smokers report more severe pain. They report more impairment from their pain. And we've also observed this among individuals with cancer-related pain. They also use more opioid medications. This is across a variety of studies. So even in post-surgery settings, if someone has a self-administered analgesic where they can press the button, smokers will press the button more times than non-smokers. If we talk about smokers with pain versus smokers without pain, again, different comparison group, they smoke more cigarettes. They're also now more likely to use e-cigarettes, perhaps to keep supplementing this nicotine intake, right? Maybe to keep those analgesic effects going. They tend to report being less confident in their ability to quit. They're less likely to initiate quit attempts. And really more importantly, and we've put out some interesting data in the past year or two on this, they are more likely to relapse. And that's prospective longitudinal data, not just cross-sectional. That is looking at over time, people with pain, less likely to initiate a quit attempt. If they do, they're more likely to lapse and subsequently relapse. If we talk about the role of hyperalgesia, now I'm going to switch to a specific study that we did. This is an interesting laboratory study. And what we did is we recruited 165 daily smokers without chronic pain. And we randomized them to either 24 hours of nicotine deprivation or continued smoking as usual. So they come in the lab for one visit, and then they come back for another one the next day. And for this study, there's many pain methods that we could talk about, but this is a capsaicin pain model. Capsaicin is derived from chili peppers, but it's not the capsaicin that you're getting over the counter at 0.001%. This stuff comes in a bottle with skull and crossbones on it that you have to then mix in order to produce what we get up to about a 10% solution. All right, and that 10% solution will not cause damage to your skin, but it will cause some degree of pain and inflammation. And both of those were outcomes in this study. Oh, and that stays on for 30 minutes. So for the sake of time, I'm just jumping right to the results of this study. And what you see there are the two groups, the people who continued to smoke in blue and those who were deprived of nicotine in orange. And on the left are pain ratings. That's on a 0 to 10 scale, but all you see is 0 to 5 because they didn't get up over 5 on average. And at the bottom, what you see is time. So they were assessed every 5 minutes for that 30 minutes. And if you conduct an area under the curve analysis, you see pretty big significant differences between these two groups after the 24-hour deprivation period, or if they continued smoking. But of course, that has caveats. That's self-report, potential experimenter effects. So what about the inflammation response? There's an actual picture of one of the arms and how it was inflamed. First, the result. The result is that the nicotine-deprived group demonstrated a greater area of flare on average than the non-deprived group. That's after only 24 hours, not even a full 24 hours of abstinence for some people. They just came back the next day. We had a minimum of 12 hours of abstinence. And then what we do, just so you get some insight into the methodology, is we take like transparencies and put them over the arm and then literally trace that area of flare and then scan that. This is what we did at the time anyway, and then compute the area from that. And that's how those measurements are done. The dots that you see on the arm there, these are all secondary hyperalgesia tests where you're taking von Frey filaments and poking each and every dot, getting pain ratings all over the place. But that would be a lot to present. These are the basics, and this is the main takeaway. Clinical considerations of that takeaway, that pain may account for important unique variants in cessation trajectories and outcomes, and that increased pain during the early stages of quitting smoking could very well precipitate relapse, right? You're getting increased pain, you're getting increased inflammation. That's on top of the known withdrawal symptoms of tobacco, cigarettes. So, and if you're not expecting them, you could see how people in pain might be at a disadvantage in the context of quitting. So what do we do about that? That's some of the current work that we're focusing on right now. In fact, we did a pilot study to intervene on that relationship between abstinence and abstinence-induced hyperalgesia, with the idea of trying a combination of nicotine replacement crossed by a brief mindfulness intervention, with the idea being that you want to prepare people for the idea that you may very well experience greater pain over the next period of time. And let's not let that throw you off from quitting. But also, interestingly, on the NRT side, let me see. Yeah, I've got another slide on that. On the NRT side, you've got the idea that you're going to use this for pain management. That's the novel approach that we're taking with this, because many people who are smokers still have tried different ways of quitting. And some of them actually have bad feelings about nicotine replacement. But our difference, our change, is that we want to suggest using this for pain management during the early stages of quitting, with the same benefits that you would get for smoking cessation, but with a different reason that you'd be doing it. That plus the brief mindfulness intervention. So we cross these in a 2x2 design. And that focuses on psychoeducation, a brief in-session practice. We're talking about 30 minutes here or so in terms of what's brief. And practicing and expecting and setting up the expectation that doing this is going to help you cope with the pain that you're likely to experience upon quitting smoking. So I don't want to present a whole bunch of pilot data from only like 20 or 30 people, but I do have one bit there, and that is the change in experimental heat pain threshold. So we did this, and then we keep them in the lab for about 2 hours and do a pain threshold test, and then 24 hours later. And what you see is this is just comparing mindfulness versus not. Okay, this isn't the NRT part, but the mindfulness training alone, just that brief setup, the expectation set, and providing a little bit of tools to deal with that, produced a lower threshold. The change in threshold was greater for the people who didn't get the mindfulness. Let me make sure I get this chart right. And we do qualitative data collection. We're coding all of that now. And by and large, people found it to be helpful. So this is a pilot study that's finished, and then we'll be preparing the R01 application to follow up on that. All right, we're moving on away from pain and tobacco for a second. And that's to pain and alcohol. Let's start with prevalence rates again. This one's a little bit different. This is representing the percent of people with moderate to severe past month pain, depending on their drinking status. Okay, so in green, we have people who drink, but are considered non-problem drinkers. And they report about 30% said, I've had significant past month pain. Among problem drinkers, it goes up. So that's people who are experiencing some degree of impairment. And then among those seeking treatment for alcohol use disorder, you get some really high numbers. Again, these are not absolute. I don't want to say 73% in every clinic is going to report this way, but that means we need more data from those clinics to update these statistics. Alcohol use among individuals with chronic pain, 28% report using alcohol to cope with pain. And that's just in the couple of studies that we've done. That's what I mean by readily report. A good percent say, absolutely, I do that for sure. They're 2 times more likely to meet criteria for alcohol use disorder than people with no pain. And they too have experienced withdrawal-induced hyperalgesia. That is, there's evidence to support that. There's also dangerous interactions with opioids and prescription opioids in particular. And that includes the increased analgesic, reinforcing, and sedative effects of said medications. 20% endorse concurrent alcohol and opioid use. Now, this is important because we're currently doing a study that I'm going to get to next that's focused on exactly this. And that's problematic because it can interfere with pain treatment, this co-use in a proximal period of time, alcohol and opioid medications. And of course, that's dangerous and have potentially fatal health effects. But before we get to what we do about alcohol and opioids, let's talk about connections between pain and alcohol, specifically pain as a motivator of alcohol consumption. So this study was the effect of pain on ad lib alcohol consumption. We recruited 237 moderate to heavy drinkers, again with no chronic pain. And this time we used that same capsaicin, but let me make sure I make this clear. In the previous study, pain was the dependent variable. In this study, pain is the independent variable. So we want more pain, but nothing dangerous, nothing that's going to cause anyone any degree of harm. So for that reason, capsaicin sensitizes the skin in addition to producing some degree of pain. And then what we do with this Q-Sense Medoc device is we use an electric thermode to add heat on top of that sensitized area, right? So you put those both together, and now you get pain ratings that are a bit higher, 7, 8, 9. And that's what you want for testing pain as a motivator of substance use. So here's what they had in front of them. 3 full pitchers of liquid. In the first 2 pitchers were 2 different domestic beers at exactly 5% alcohol each. And in the third pitcher was seltzer water, because we don't want to test the effect of pain as a motivator of wanting to drink fluids. We want to test it as a motivator of wanting to consume alcohol. So that's the procedure pretty much laid out. This is hot off the presses. This was literally just accepted in Journal of Psychopathology and Clinical Science, which, in case you don't know, is the new name for Journal of Abnormal Psychology. And so I don't have these 2 fancied up yet, but these are the primary results from that study. And what you see is in blue, the pain induction condition, and in, I guess, lighter blue, the no pain condition. And in short, what we found was that people who received the pain poured more alcohol, consumed more alcohol, and reached a higher blood alcohol content level. So that supported the hypothesis. And another interesting thing about this is we do these sub-analyses to focus on different groups. And we found that it was most pronounced, this effect, among those who are self-identified as male or Black relative to female or white, respectively. That's a smaller part of the bigger sample, so that requires replication and follow-up. The implication, though, much like I laid out earlier, that current drinkers may be susceptible to escalating their consumption of alcohol in the context of pain, potentially leading to alcohol use disorder. All right, we're on the last example. I feel like I'm talking fast and a lot. And there's a lot of information I think I'm putting out here. But this one is ongoing, so I don't have results to show you. But I would like to tell you about some of what we're doing. This is a current NIAAA R01 project, which is to address hazardous drinking and alcohol opioid interactions among adults with chronic pain. So first, hazardous drinking. That's a pattern of alcohol consumption that increases risk for harmful consequences and alcohol use disorder. There's lots of different labels for problem drinking and hazardous drinking, but this is the definition that we're applying for this study. And now I want to talk to you about personalized feedback interventions. This is not the first one we've done. We actually did a personalized feedback intervention for smokers who were older adults with chronic pain who also had HIV. And that was our first study that utilized these methods. But what's really interesting about personalized feedback interventions is that they're intended to motivate change ultimately. And they do that by providing psychoeducation, so some information, but also normative feedback, which is what do I think the rest of the world is doing versus what are they actually doing? And then personalized feedback. So this one's interesting in that people who take a PFI, or even if you administer this in the clinic, they can sit there on a phone or a tablet and they answer some questions about themselves. And then those questions are immediately and dynamically piped in to the presentation that they're about to get. So it's immediately personalized right on the spot. And that's what they're receiving. So it's this combination of personalized, normative, psychoeducational information, but not in an overly aggressive way, I think, but in a way that leaves room for change in that motivation. So that's what those are in general. Those are adaptable across healthcare settings. They're easily implemented. And importantly, they don't require more effort from the people who are already expending huge amounts of effort in the delivery of clinical care, right? So that increases accessibility, maybe overcomes some of those barriers. And the implementation of it is inherently more feasible because you don't need more person power to do it. All right, so this study, ongoing, our goal is to recruit 174 hazardous drinkers with chronic pain who are prescribed opioids. And this is in two phases. One is the developmental phase, and two is the randomized controlled trial phase. We have completed the developmental phase. We are well into the RCT phase for this. And that goal is to reduce hazardous drinking. So not just co-use of alcohol and opioids, but we're using this as an opportunity to address hazardous drinking in this population, but also hopefully to reduce or eliminate this proximal overlapping use of both substances. Again, I don't have results to present to you, but I do have a few examples of some of the information they get. These are from the actual slides that people get once they complete the baseline portion of the questionnaire. And just to illustrate a few, again, I don't know how well you can see that, but the first one is this kind of normative comparison. And it says, how many days you drink? So that's personalized. They've reported this. And they said 6 out of 7 days I drink. And then how many days do you think a typical adult drinks? And there you say, they thought it was 7 out of 7. Like, I think other people probably drink more than I do. And almost everyone actually thinks that. And then they go, how many days the typical adult actually drinks? So this is based on available data, nationally representative data, and we found a number right around 1.8. So again, you see this discrepancy between what they said, what they think, and what is. At the bottom right, that one's more focused on this proximal relationship between alcohol and opioid use. And in doing this work, we really came to find that there's important distinction between using it in overlapping ways. So like in my life, I take opioids and I drink alcohol versus in the same day, which increases that risk level versus within 2 hours of each other, right? And that's what you see here on the bottom. And before I walk through those 2 bars, I just want to say that the same day group doesn't necessarily realize that some of the opioid medications that they take are long release. So if they think, oh, I took this morning, but at night I'm good to go, they might be mistaken in that regard as well and could benefit from information pertaining to that. So again, this personalized information, in this case, the participants said that they thought 55% of people use alcohol and opioids in the same day. And then we report our best statistic that only 20% of people actually do this. That actually makes our recruitment challenging because only 20% of people actually do this, and we need to find them and get them into the study. And then use of alcohol and opioids within 2 hours, they say a similar thing, but the data suggests that only about 12% of people do that. So again, what we're trying to do is create a discrepancy between what you say you're doing and what you say you want to have happen, which is, for many people, improve pain relief. We also include knowledge questionnaires, things that are based on scientific fact or evidence that we've derived. And we also get people to think about their beliefs about alcohol and opioids. So we're introducing the idea that there are dangers here, but they get to review and click on, interact with this, ones that they feel resonate with them the most. And that's important. You got to keep that interaction in this process, that engagement. And then lastly, because those are just static pictures and none of these happen statically, I have a very short video of how these things move. And this is what it looks like. So why should you reduce your drinking while taking opioids? Now it's an opportunity to select things that matter to you, trying to make the case that there are things that matter to you way more than using alcohol and opioids in this fashion. And this is after they've gotten information about what some of the consequences of that are. Now introduce the idea of change. What could you change? We're not saying you need to change this, right? What matters to you? What would you consider doing that might change this trajectory? So I don't know if you can see it, but they selected, don't have alcohol in your house, don't drink on days you take your medication, and bring a non-alcoholic beverage when you hang out with friends. So they have several things to pick from that are tools that are commonly used in the reduction of drinking and hazardous drinking. But instead of saying you need to use these, hey, you pick a couple that you think would work for you. And even if they don't go home and do that day, we've introduced the idea that you might consider doing this. So I'm guessing before they saw this, they weren't thinking about that. And our goal is to get them to think about that. So then we follow them up 3 and 6 months later, and we will see what happens in terms of their drinking and their alcohol opioid use trajectories. So as I wrap up here, I'm very close to the end. Future directions, I've covered a few already, but a couple of specific ones is to get this work integrated into patient-oriented clinical programs. That is bringing substance-related interventions into the pain services, bringing pain-related interventions into the addiction services, but more importantly, creating novel interventions at the intersection of these and bringing those directly to patients. So we can inform and include community stakeholders in the development of these to develop culturally sensitive integrated treatments that are disseminable. Ultimately, to increase access and overcome some of the barriers that exist in the goal of improving community mental health and wellness. To do that, we have to continue to identify and address social determinants of health. That is to ultimately, as I mentioned before, advance health equity in pain and addiction. And to do that, we need to leverage emerging and impactful data. One of those is currently underway, a historic effort by NIH. You may or may not have heard about this. The reason that I'm mentioning it here today is because we are using this data. I headed up our institution's access to this data. I looked this up. University of Rochester already has access to this data, which means you can just go through a simple application process institutionally. And this is ultimately to develop the largest and most diverse biomedical health data resource of its kind aimed at precision medicine. These efforts are ongoing. It's not just self-report stuff. They have biological markers. They have physiological data. They're going to track people over time. They have genetic data. This is going to be a big deal resource. So if you haven't heard of it yet, that's why I wanted to share that with you. And ultimately, emerging approaches to managing chronic pain and substance use I'm interested in exploring those, including the potential utility of cannabis and psychedelic medications in this context. In conclusion, the translational, transdisciplinary study of interrelations between pain and substance use, I think, represents a significant and still emerging area of great clinical and empirical interest. And pain and substance use likely interact in the manner of a positive feedback loop to influence their respective trajectories and outcomes. I'd like to acknowledge collaborators at a variety of institutions, not all of them included here, but to do this kind of work, you do need to connect with many other people. And I'm thankful for those relationships. And then at that point, I say thank you and open it up for questions.
Thank you so much to Dr. Ditre for a very thoughtful presentation about your ongoing work and about lots that has implications for this audience. I've got two things going. One is a microphone and looking at all of you who are in the room to see what questions you have, as well as hopefully the ability to monitor the Q&A in the chat. So I'm going to start with the Q&A because I do see one popped in here, and then I'll turn to the audience as well. One comment so far that says, great talk, Joe. I think this is someone who knows you from dinner last night. I'm wondering if you've considered potential adaptive coping strategies for pain within PFI, or if you connect the dots that some of the strategies for reducing alcohol use would be helpful for impacting their pain, since reducing alcohol use then takes away from one of their current important, albeit harmful, coping strategies.
Yeah, that's a great question. So in the context of a PFI, you don't have a lot of space to work with. You don't want to overwhelm people, and the number of slides can become too many too quick. But there are other interventions that we're interested in working on, including behavioral ones that involve some form of counseling and intervention. And there's actually another project that's getting ready for submission, which is focused on smoking cessation. And what that one does is it directly implements intervention to address fear of pain and physical movement. So I think depending on the modality that you're using for treatment, you can do much, much more than what we covered in the PFI here. Yeah.
Great, thank you. Brian.
Yeah. Yeah, no, that's a great point. So there's so many different angles to potentially address this from. And I know from what I presented, it might seem like there's a lot out there on this, but there isn't, right? We're not there yet. So taking different perspectives, I mean, in terms of personality and even personality factors or vulnerabilities, transdiagnostic vulnerabilities that cut across these conditions, that's another important next step. I just didn't want to overload the presentation, but you raise a great point because there are common factors that underlie both the onset and then the maintenance of these. And I think by targeting those, we can have impact in both directions, which I think is what you're getting at. Yeah, thank you.
I've got probably a piggyback question of my own, which is about self-efficacy as a mediator of both pain experience and substance use disorder.
Yes.
So in looking at some of your data, thinking about people who are experiencing pain, if I'm experiencing pain, which I don't, thankfully on a regular basis, my belief in my ability to manage routine things is affected by that. So I'm curious if any of your work has looked at self-efficacy as a mediator.
Yes, absolutely. Social cognitive theory, incredibly relevant to all of these considerations. And in fact, my dissertation focused on increasing self-efficacy for managing urges to smoke in the context of receiving pain. That's another study that I didn't present here, but it's not just self-efficacy, but also magnifying that, right? Augmenting it, increasing the belief that one can be successful treating the other condition while addressing both at the same time. So one way to do that is to address their expectations, their outcome expectancies for what will happen if I do this. But then to get there, you have to increase their self-efficacy, their belief that they can execute those behaviors to achieve those expectancy outcomes. So it's all highly central to this work, definitely.
In looking at who we have in the room, we have folks who probably focus more on pain-related distress and others who focus more on when substance use disorder is already present. So I'm just aware that we each probably are seeing patients all over the spectrum and co-occurring experiences. Other questions from in the room or online?
Experimental study and the experimental work you're doing is really compelling. How do you think about that type of pain? Is that acute pain you're inducing or chronic pain? I would think that chronic pain is the bigger culprit with substance use or nicotine use, other drug use. And is there a good experimental approach to generating?
Yeah, that's a great question and a great
Sorry to
point.
interrupt. Could I invite you to please repeat the question for folks on Zoom?
Oh, may I repeat it?
Please.
Let me paraphrase.
Okay, that's great. Thank you.
So it has something to do with the idea that these experimental procedures that one uses to invoke pain may not be representative of the experience of people with chronic pain. So therefore, you have a gap between the experimental studies that you're doing and how it applies in real life. And I think that is a critically important point to make. The answer to your question of is there one is basically no. There is no great analog for chronic pain in an acute or experimental pain. There are a whole range of different kinds though. I mean, you can stimulate guts internally with needles. I mean, you can do more invasive things than you can put capsaicin under the skin, not just on top of the skin. But no matter what you do, you're not going to achieve the level of impact and extended pain-related affect that you get in the context of chronic pain. Now, in fairness to the design, because no one had done that kind of study before, internal validity was the prepotent focus. And for that reason, you wouldn't want to recruit people who have chronic pain if you're testing the most basic mechanism of does this experience of pain prompt anyone to use substances. And the reason that work is done is because it's based on animal models that had all come before that we didn't really pay that much attention to. In fact, when I talk about abstinence induced hyperalgesia, the fact is that in the animal world, increased pain is indicative of substance-related withdrawal. It's actually a way that they test, are these animals in withdrawal? But they do it in the context of withdrawal, and they don't talk about it as pain, even though the methods that they use are these paw and tail flicks and other things that are all pain-related. So we're able to extrapolate from that, do it in humans, again, with as clean a sample as possible to reduce variability. But it's incredibly important then to move that on to a chronic pain sample and a real world sample. And I'm just building up to that stuff. So that's the basis for doing that work with people with chronic pain. I think we could do that via EMA studies that follow people over time, and you can see the covariation between their pain experience and their behaviors. You can replicate some of the experimental studies that we did in chronic pain populations. The device that we use, the Medoc Q-Sense, is pretty much considered a gold standard pain assessment technology. And you can get at things like pain inhibition and pain facilitation, which are just as relevant to people with chronic pain as without. But what you don't want to do is jump from the animal studies to inducing pain in people who already have pain, right? Without a basis for doing that. So I see these as like the initial steps in that human work.
Thank you. I do have one more question from online, and more kudos and appreciation for your talk. This question is about genetically informed work on the longitudinal and bidirectional associations between pain and substance use, and sort of what's out there, perhaps with a particular focus on how those associations might play out, like in twin studies.
Yeah. So that work, again, has mostly been done in isolation, right? You have good genetic work looking at predictors of substance-related outcomes and pain-related outcomes. We have started to do some of this leveraging polygenic risk scores in the prediction of some of these behaviors, but we are just scratching the surface at looking at pain and substance use as a comorbid condition, to even think of that, and then to look at what might predict that, this is all very new. So that is absolutely where you need to go next, because you're going to find patterns and inform precision medicine approaches going forward. Yes,
So like next week, maybe you'll have some data on
I'll
that.
work on that.
That's great.
Yeah.
Well, please join me in thanking you, Dr. Ditre, for your very thought-provoking talk, and thank you for coming this afternoon.
Thanks, everybody.